really jam-packed schedule for us today. My name's Adam Houston. I have the privilege of sneaking out for an early lunch from Doctors Without Borders to be your moderator slash MC for today's event, which is, of course, hopefully you're in the right place. This is the Stop TB Canada World TB Day webinar. So, uh, just in deference to the people trickling in, I'll try not to say anything super, super important for the next couple minutes. But it is nonetheless important to know a little bit about Stop TB Canada. Stop TB Canada is a network of people committed to ending TB, both here and abroad. This is a network of researchers, of healthcare practitioners, of advocates, of TB survivors, and others. If you would like to know more about Stop TB Canada, including about, upcoming events like this one, um, or perhaps you'd like to get involved with Stop TB Canada, please check out our website, which is stoptbcanada.com. Since this is our event for World TB Day, even though we're doing it a little early, actual day is, of course, the 24th. I would like to take a moment just to say a big thank you, first of all, to all the members of Stop TB Canada. This is a volunteer-driven network, and we've really accomplished a lot thanks to all of you sharing your time, sharing your expertise. So thank you. I would also like to thank our lineup of speakers today. Very exciting lineup that we'll get to very soon. Thank you also for sharing your time and your expertise. And of course, thank you to all of you tuning in to watch this. As we mark Stop TB Day, World TB Day this year, this is, of course, a very challenging time for the TB community, internationally. A lot of changes, a lot of big funding cuts, really impacting research, impacting patient care, and so on. And so it's really important to be coming together, because the best way to be meeting this challenge is, of course, as a community. So thanks again to all of you for being here. Now, just a couple of housekeeping things before we get underway. First of all, this session is being recorded. So, if you are on camera and still in your pajamas, fair warning. Second, we will be taking questions for everyone, but right at the end. We'll do all the questions at the end. So hang on to your questions, and we can take those questions either in the chat or on camera with the microphone, etc. However, that does mean I would like to remind you, and everybody's doing it so far, to please keep your microphone muted until the questions. Other than that, for our speakers, thank you again for being here. There are quite a few of you, so we do need to get to you all. So I'll be giving the short version of your introductions. We'll put the longer versions in the chat. And also, I am tasked with the slightly unpleasant task of keeping us to time. So I will give you your full allotted amount of time, but when that's up, I will come on and kind of ask you to wrap up in 30 seconds or so. Finally, just an extra special shout out to Lee Wraithby, who is, I'm just the figurehead here. She's the one putting all this together and making sure that this webinar goes smoothly. And time permitting, hopefully we'll see her at the end to tell us a little bit about what's happening on actual World TB Day. All right. Without any further ado or any further Adam, let's get to our first speaker, providing a TB nurse perspective, talking a bit, I believe, about the North here in Canada, is Lynette McElroy. Lynette.
My speaker on. Hi, good morning. Thanks, Adam, for the introduction. I'm just so excited to be here. So I'm speaking to you today from Salt Spring Island, where I live, which is included in the unceded territory of the Coast Salish people in British Columbia. I wanted just to mention, as it's Adam didn't share with you, but I started working in tuberculosis in 1994. And I'd been out of school for a couple of years at that time. My kids were 10 and 5, and frankly, a Monday to Friday daytime job that was part-time seemed like a bit of a dream. So I applied. I knew very little about TB, and I actually intended only to stay a little while because my dream job at the time was to land a permanent position on the postpartum unit where I had done most of my practicum and my years of nursing up until that point. Um, so here I am, 31 years later. And this is actually my dream job. And it probably occurred to me that it was my dream job within, I would say, a few months of working at the TB clinic. As most of you probably feel as well, if you're involved in TB care, this is such an interesting disease, but I think it also gets us in our hearts when we're working with people and families and communities that are impacted by TB. And especially because many of the people we're working with are living in situations that are inequitable and socially the social justice gaps there that you just can't not help or want to help. So anyway, I'm getting back to the presentation. As you've heard from Adam, he's got a big shepherd's hook there at 5 minutes, and I'm going to apologize to you for reading through my notes today, but I really want to keep to that time out of respect for all the other great people that will be speaking with you today. So I'm happy to be here, honored to be here, and I'm going to be sharing some of my perspectives from my experiences about TB drug access challenges, and also sharing some sort of hopeful remarks towards the end. So 5 minutes, not a second more, here goes. I want to preface what I'm about to say by sharing that I've never been diagnosed with TB or TB infection. I didn't get BCG vaccine. I've never taken any TB drugs. And I recognize that I'm speaking from a place of privilege compared to many of the people and communities I've worked with in that regard. So having said that, though, I do consider myself as having been affected by TB. The many things I've seen and been involved in and heard and learned over these years working in the profession has left me feeling that way in good and bad ways. It's part of the reason that I'm still here. You're going to hear a lot today about access to TB drugs from a bunch of people who care very much about that subject. But my goal in this space, I think, or the way I'm interpreting it, is to remind us that we actually have many tools already that we have at our disposal to end TB. Many of them were in place from that first day at my first day at the TB clinic way back in 1994, including tuberculin skin testing. Like for more than 100 years, we've had that test. We've got X-rays, we've got culture microscopy. We heard yesterday in another fabulous webinar from Dr. Cooper, who reminded us that we've had INH since the 1950s. And so it was a bit of a moment for me being reminded that that's 70 years we've had that drug. When I started working in TB, I used to say to people, this is a very safe drug. We know how it's used. We've had it for more than 40 years. People starting out and people working today, when they refer to INH, they're going to be able to say, we've had this drug for 70 years. I think that's a good and bad thing because it's still, the foundation of a lot of the work that we do. We've had rifampin since the 1970s, which again, back when I started, I'd say that's, we've had this drug for about 25 years. We're pushing 50 on that one, It's still a mainstay of a lot of the work that we do. The way I see it, every tool that we've come up with since that time have been refinements on what we already had. I think that we continue to search for the silver bullet or bullets and look to those future things to solve this problem of TB and help us end TB. But I'm not sure that that's necessarily where our focus should be all the time. In my early days, going to the TB conferences and meeting with people and building my network of people, there was a physician, some of you may recall or know, Dr. Ann Fanning, who would often stand at the microphone and share her thoughts and perspectives. And I'm sort of tapping my inner Dr. Fanning right now, considering myself a senior in the work of TB and sort of, I guess, playing my age card to be a little bit cranky, to say that I think that sometimes we put our emphasis on the wrong syllable, which is something that Anne used to say and used to drive me a little bit crazy. But I get it now. I get it, Anne. And I think I just want to remind us all about that our challenge is not finding the next silver bullet as much as it is using the ones we have and deploying what's at our service while we continue to refine our tools and think about the way forward and making things better and shorter and more effective and more accessible and those things. So our practices in TB must be safe, obviously. They must be effective. They must be acceptable. And I know that we're going to talk today about formulations for children. It's not just children that can't swallow our drugs or take our drugs. Some adults can't either. So this idea of having these medications that are dissolvable, it appeals to me on many fronts, but of course, especially with children. But our practices must also be accessible. And so I listed off a bunch of things that we've had for many, many years. Some of those things are still not very accessible.
Hi, Lynette. Sorry, just that's your countdown. Thank you.
Great. So I'm almost done. So as we listen to the presentations today and after we leave the session, I really want us to be thinking about accessibility. And I have one picture to share with you that many of you have probably already seen. It's from the Inuit TB Elimination Framework. It speaks to not just equality, but equity, and recognizing that sometimes the lift has to be bigger for some populations than others. So with that, I'll leave you. And again, thank you for including me in the session today and wish you all a very good webinar and a fantastic World TB Day next week. Thanks.
All right. Thank you very much, Lynette, for kicking us off. Next up, we've got Cherise Scott, who is the Senior Strategy Manager at Unitaid, telling us a bit about recent advancements in TB treatments and efforts to improve access globally. Cherise, over to you.
A good day, everyone, and thank you for this opportunity to present on behalf of Unitaid, and then also building on what Lynette has mentioned and building on that hope. We know that every year millions of people fall ill from TB, and too many still face long, difficult treatments or barriers to accessing care. But as mentioned, we have major breakthroughs in treatment and prevention that are changing the way TB is tackled. It is offering new hope for those affected by this disease. And as we know, for World TB Day, it reminds us that the right tools and the right approaches can lead us to a TB-free future. The challenge now is ensuring that the latest advancements in treatment, prevention, and diagnostics as well are available to everyone who needs them, wherever they live. And Unitaid is at the forefront of that. We've been very investing, working with partners across all major stakeholders, whether directly investing in specific projects and working with implementers on the ground in countries, or partnering and across the landscape, thinking through different strategies for access, working with partners like Global Fund, Stop TB Partnership, and many, many others. We're trying to accelerate the development and implementation of shorter, safer, and more effective TB regimens. So getting into this new era of TB treatment, where we now do have shorter, safer, and more effective treatments, starting first with drug-resistant TB. As you've seen over the last year or two, that there's been major efforts. We now have BPAL-M, which is a 6-month all-oral treatment, replacing an older toxic injection-based therapies, and now it offers a significant opportunity to really see transformative care for people who are affected by drug-resistant TB. In addition to that, through Unitaid's direct support, we've included alternative regimens for those who cannot take BPAL-M, including children and pregnant women. So now we have other all-oral regimens as well that are better, less toxic, and then sometimes cost-effective in treating, and so allowing for all those affected by drug-resistant TB to have a treatment option that is better. And then, in addition to that, when we think about drug susceptible TB, we do have also on the market and available various treatments that can reduce the time for children and adolescents with non-severe TB. So we have a 4-month regimen instead of 6 months, making a huge difference for young people and their families.
Sorry to
And
interrupt, Charisse. If your slides are meant to be moving, they're not moving.
Oh,
We're just
oh,
seeing
sorry.
the first one there.
Okay. Thank you for that. So this gives you an overview, kind of thinking through the cascade as we think about those who are affected by TB in different categories. And so, as I mentioned, drug resistance has had one of the most recent and major transformations in TB. But in addition to that, we've had some significant advancements on drug susceptible, as I mentioned, with shorter 4-month treatments for non-severe disease. And another area, thirdly, is preventive TB treatment, where we've seen for the first time through Unitaid's investments and working with partners in South Africa, Stellenbosch University, we now have a treatment for the first time, preventive treatment for drug-resistant TB with levofloxacin. So that's a huge, and that's not just for children, it's also for adults. And across all of these categories, we've worked with partners and industry, and particularly generics, to make sure that there are child-friendly, or we call people-friendly formulations for all of these drugs that are in these regimens. So now, for the first time, we have better formulations for children as well as adults to make sure that they can effectively take these regimens. So as we know, that the challenge now is making sure these groundbreaking advancements don't stay on paper, but actually reach the people who need them. So making TB treatment and prevention accessible for all is our primary work now. So our approach, and we're working with partners across the spectrum, is to ensure that access to new treatment and prevention tools have a concerted effort and a comprehensive effort. So one, thinking through market shaping, what are the tools, not just treatment and not just the medicines, but also the things that are supportive of treatment. Do we have low cost options, things that are cost effective to programs, to patients, to communities in high burden settings? And then also informing implementation. How do we look at how to support national adoption and introduction and so forth with key technical assistance and so forth. And then the last aspect of this, and which we're very excited about, is putting more investments, and which is much more needed now than ever, in community and civil society leadership to drive demand creation, to also think through, we need to find those who are missing to get them on treatment. And so how do we do that? And a lot of that can happen and will happen through innovative approaches that are led by community and civil society stakeholders. And that will also help break down stigma and promote early diagnosis and treatment. So these efforts are making a real difference, but we still need to keep vigilant and make sure, especially in this current environment, that we can continue to sustain our investment and collaborations to ensure uninterrupted services, even in this time. We know what happened during COVID with a lot
Your
of
countdown, please.
disruptions. Okay, thank you. And but this means that we need to still work across sectors: public health, finance, civil society, and private industry. But we know that scientific advancements in TB treatment prevention represent a significant step forward. And Unitaid is ready and willing to walk hand in hand with our partners to make sure that we get the right access. Thank you.
All right. Thank you very much, Charisse. Next up, we have Madeline Nash, who I've known wearing many hats in TB, but I currently know best as a fellow member of the Stop TB Canada Steering Committee, who will be talking about barriers to accessing TB medicines in Canada, including Stop TB Canada's Access to Essential TB Medicines in Canada report, which I'm sure will materialize in the chat. Take it away, Madeline.
Thanks so much, Adam, and thank you to Charisse and Lynette for setting the stage so eloquently for this presentation. I'm really pleased to be here to share the results of this work on behalf of the entire Stop TB Canada Steering Committee. So based on how Adam's keeping time, we'll jump right in. So essentially, the bottom line is that the mainstays of TB treatment are simply not available as accessible as they need to be in Canada, and that's because they're not marketed in Canada. And this is a result, of a business decision on the part of pharmaceutical companies who, due to the relative small market size of the population affected by TB in Canada, have chosen not to market their drugs here. And the result of that is, ultimately no or very restricted access to what is now the standard of care for TB treatment globally. And I think the top of mind for people when we think about this issue is really, how does this lack of access affect patient care and patient's experience and patient outcomes? And I think looking at a lot of these questions, do access barriers lead to treatment delays? Do they lead to increased work for providers, for families? I think for people, many of whom are on the call today that have been involved on the front lines of TB care, the answers to those questions will seem really intuitive and obvious to be a resounding yes. But I think the reality is that in the Canadian context, we, until now, haven't had much systematically collected evidence to really base these claims on. And that leads us to what we're going to discuss today, which is the results of this survey that Stop TB Canada conducted. I just want to take a really brief detour just to talk about how I got invested in this work. I think it kind of sets a good context for the background to some of this some of these advocacy efforts. And it goes back to about spring 2018, when I first had the privilege to travel and work in Nunavut. And as part of the work that myself and colleagues were doing there related to TB, we were able to attend some house visits with nurses and community providers who were administering TB therapy to children. And I was really shocked to see the method of TB treatment delivery to children, which was, pill cutters and mortar and pestle and mixed in food, and providers spending hours in vain trying to get mostly really young kids to try and take their therapies, day in, day out for months. And I was shocked about this because I had just previously been working primarily internationally in TB, and I knew that we had access to child-friendly formulations for several years, even at this time, 2018, and that these formulations had been really hard fought to improve the quality of care for TB for kids. And I knew that the Canadian government had been substantially involved in subsidizing access to these formulations abroad. And so, this sort of launched an advocacy effort on behalf of myself and many people in this space, colleagues and other organizations, trying to challenge, what we really saw as a double standard in TB care. This need for these formulations and also for other new technologies, TB was also highlighted around the same time in the Inuit TB elimination framework. And we had several meetings with government officials, and the refrain we kept hearing was, well, what's really the scope of this issue? Like, what's the impact? We don't really have any data to show that this is really important, or this is really an issue, or that these formulations would make a difference. And so that's what sort of brings us to the impetus for the survey. And members of Stop TB Canada, several of whom have been involved in TB care in Canada for decades, they wanted to do something about this, and as has been mentioned several times on the call already, we're a volunteer-run network with not even limited resources, but zero resources. So we thought, what can we do to try and, shed some light on this issue? We can do a survey. So we elected to do a survey focused on documenting healthcare providers' experience with these barriers to TB medications in Canada, accessing TB medications in Canada, and what their perceived impact was on the quality of care and the access to care for their patients, with the aim of producing some recommendations for policymakers and hopefully inspiring the type of policy change we've all longed to see in this area. The survey was available in French and English and disseminated widely by email. We got really good response rate, over 70 healthcare providers from 10 provinces and territories, a majority of whom were practicing largely in Ontario and in Alberta. I just want to cover the two pathways that exist for access to non-marketed drugs in Canada. Hopefully, which will be the only two acronyms you'll hear today. The first is the Special Access Program, or the SAP, which is a program that allows individual physicians to make requests on individual patient basis to get access to drugs which are not marketed and not approved by Health Canada. And the second is the ADEC mechanism, or Access to Drugs in Exceptional Circumstances, which, in contrast to the SAP, requests are made by jurisdiction, not a physician, and the procurement is more bulk over a defined period of time, as opposed to on an individual patient basis. But drugs can only be procured through this mechanism when they fall on this list of drugs for urgent public health need. And I think it's interesting to note that, as of right now, rifapentine, one of the mainstay drugs in TB treatment, is the only drug that currently exists on this list. So ADEC and SAP, those are your acronyms. So I want to cover, in the short time I have, the three large findings from the report. The first is about the poor access to treatment for drug-resistant TB in Canada, namely related to bedaquiline, pretomanid, and delamanid. And I'll just touch on rifapentine at the end of the slide. The long and short of it is respondents reporting really unacceptable delays in treatment initiation because of these access barriers. So delays of 3-4 weeks, and some provinces, reporting delays of 4 months or more. And those delays of 4 months or more were significant in certain provinces. And so with that finding, it's unsurprising that 75% of respondents agreed that these pathways are really insufficient to provide patients with timely access to care. 2/3 felt that these access barriers were contributing to unfavorable outcomes for their patients. And interestingly, 1 in 2 reported hesitancy among patients to take drugs that weren't approved by Health Canada, which is the case for bedaquiline, pretomanid, and delamanid. For rifapentine, we inquired about the same questions, and the situation was slightly more positive for access to rifapentine, but still far from ideal, especially in certain provinces. The qualitative responses really focused on describing what we mean when we say kind of administrative burden for these pathways, and really detailing through that human experience, what that really means, the significance of that, and the perceived impact on patients related to side effects, hospital administrations, and patient experience. And why does this matter? I think, based on the names I've seen on the call attendance, everyone knows TB is still a major public health threat in Canada. And while drug resistance isn't necessarily our leading problem, it's still over 1 in 10 people who are diagnosed with TB have a drug-resistant strain that may need treatment with one or more, likely all, of the drugs that we just discussed that have such significant access barriers in Canada. Second finding was about the harms caused by the current method of pediatric treatment administration in Canada in the absence of child-friendly formulations. Respondents strongly agreed that this reality is posing problems for treatment completion, resulting in high attrition, poor outcomes, trauma for patients, their families, and significant time burden for already overstretched healthcare providers and for families. I think this section is one of the most striking of the entire report. So I really encourage you, if you read anything, go and have a look at this qualitative section in terms of pediatric formulation access. Really compelling, poignant stories from providers about kids needing nasogastric tubes, needing prolonged hospital admissions away from their family, about needing to be pinned down, kids needing to be pinned down by their family members in order to get these drugs administered, and that kids are actually stopping very important courses of TB preventive therapy because of the challenges with drug administration. Why does this matter? Again, kids affected by TB in Canada, the national rate suggests about 5% of those diagnosed with TB in Canada are under 15. But I think that it's important to look at the province level data, which shows that some provinces are dealing with much higher burden of pediatric TB. Saskatchewan, for example, among Indigenous populations, as many as 1 in 4 people who are affected by TB are children, many of whom can't swallow pills. And I think Lynette made a really good point that it's not just children, other people struggle to take a pill form medication, and that just extends the impetus, for these medications. And I personally worked in outbreaks where the percentage of pediatric affected populations was, as many as 80% of the cases in an outbreak. So it's really a substantial burden, and it's an equity issue because the majority of kids who are going to be affected by TB in Canada are Indigenous kids. Those are kids that are already, if not themselves, have the experience of medical trauma. It will be in their family. And these are kids that are most likely to be living in the more rural and remote and underserved communities that are less likely to have access to, for instance, compounding facilities that may be accessible in more urban academic centers. The third finding is about shortages, reinforcing that provinces and territories are still facing continued shortages, primarily of rifapentine. And people also spoke to the fact that there are a significant issue in terms of notification about shortages because these drugs are not approved by Health Canada and therefore don't fall under the existing mechanisms for alert of shortages that those drugs do. And this is significant, right? Because this is the only way providers can make Plan B and provide that continuity of care for their patients. And it's not just the non-marketed drugs. Also, we have issues in terms of shortages for much older and other drugs. So where do we go from here? The report highlights several high-level recommendations, the first of which is about establishing appropriate obligations and incentives for pharmaceutical companies. And I just want to emphasize, this is not talking about cutting big checks for pharma companies. It's talking about what are the levers that exist in our current system that we can pull to help ensure people in Canada have access to the most high-quality care available, because that is not on the agenda or in the decision making frame of mind of companies that are making these decisions based on our bottom line. That's not their responsibility, and they're not going to do that. So that really falls on us as a community, on our governments, to make sure that we are finding ways to make that happen. The second is about the need to simplify and expedite the existing mechanisms that we do have. So this is about shorter term while we work on these longer term, regulatory changes that need to happen. It's clear from the survey that those mechanisms, SAP, the ADEC, they are not fit for purpose of providing patients with the quality of care they deserve. Third, we need to make child-friendly formulations available in Canada. We're not the only low-burden, high-income country that's facing this problem. Others have succeeded in bringing these drugs into their countries for their citizens. Canada can do it, and we need to do it. And the fourth is about ensuring a stable supply of TB medications, developing a national procurement strategy, potentially developing a national rotating stockpile, and exploring what is needed to ensure continuity of care for people affected by TB. And I just want to emphasize that for once in TB, we're not talking about a failure of science or innovation or even of resources, which I think what these recommendations highlight is that this is a policy failure. And what is a policy failure if not a failure of imagination and will? And I just say that to remind us that I think this is within our capacity to do something about, and therefore we should do something about it. And we shouldn't wait, because this is not a new issue. I think this is something that has been a problem for at least a decade for some, and for some things longer, and the time is really now. And last slide, I think a lot of the recommendations that we put forward in the report, they're really targeted at probably the federal level in really demanding federal change, potentially legal change, regulatory change. But I know there's a really diverse audience on this call, and I think it's so important that we all work on this together and that we all recognize the role that we have to play. So I just wanted to draw attention, for people on the call that are part of TB programs or who are researchers, what you might consider doing to get involved in this effort. I think for programmatic, for programs, TB programs, programmatic staff, data collection, documentation, to see what you can do in your program to collect data on these access barriers and on the consequences for patients, and use that data to advocate at the provincial and territorial levels. And for researchers, I really hesitate to call for any more research on medications that are, already proven to be efficacious and that really represent the standard of care globally. But I just thought, perhaps there's creative ways that through existing studies or new studies, we can improve access to these non-marketed compounds in the interim, and perhaps offer more insight into really the clinical questions that obviously we were getting at sort of from the side with this survey about perceived impact on patient care and on outcomes, but weren't able to measure, objectively like you would in a clinical study. So with that, I just want to thank you all for your attention. I really want to thank all of the providers. I know some of whom who are on the call who took the time to complete this survey, because I think it really is going to make all the difference. To thank all the members of the steering committee who dedicated volunteer time to make this possible, and especially to Dr. Lena Frost, who prepared the survey questions and did the quantitative data analysis and was very diligent in getting it all prepped before her maternity leave. So big thank you to her. And with that, I am going to wrap up, and there's many members of the steering committee who are online and available to answer questions when the question period arises. So thank you very much, and I'll turn it back to you, Adam.
All right, thanks very much for that, Maddie. I didn't want to cut you off while you were thanking us, so and please, everyone, the report is in the chat. If you haven't had a chance to take a look, please do so. However, next, I have the privilege of we have someone who will announce some positive news toward access to medicines in Canada, which is always a fantastic thing. We have Sandeep Juneja, who is Senior Vice President of Market Access for TB Alliance. And Stop TB Canada's response on this particular issue will appear in the chat, but Sandeep's going to update us on access to Protomanid here in Canada.
Thank you, Adam. Pleasure to be here, and thanks for having me. The situation was a few weeks ago, we learned that there was problem accessing Protomanid, which is a key element of a new standard of care for MDR-TB, that is BPAL-M regimen. PA or PAP part of it is Protomanid, and that was not easy to access in Protomanid in Canada. And Protomanid is a drug developed by us, by TB Alliance. So we got very concerned about it, and so that's what this is about. And we work with our manufacturer who distributes the product in Canada, and found solutions working with Stop TB Partnership and the physicians who treat people in the country, and we were able to cut that time down to a week. Now, it is not 3 days, which is what we were aiming for, but it's a remarkable improvement from 24 to 31 days that it was taking, and definitely a very good step in the right direction. And hopefully we'll be able to bring it down further. So, and for those who are not familiar, TB Alliance is a nonprofit organization that works in discovery, development, and delivery of improved, faster acting TB treatments. And before we began working, MDR-TB treatment used to take up to 20 months, and it's now down to 6 months. And the cure rates used to be very low, sub 50%, and now they are in the 90% range with this new medication. So I'd like to really thank Stop TB Canada and the physicians in Canada for bringing this to our notice. Once we knew about it, we didn't need any convincing that this was a critical problem to solve. Delays in treatment initiation, prolonged suffering, we all know that. and they more importantly, they affect treatment outcomes if you start late. So with that in mind, we didn't want to lose time. Uh, and thankfully, the manufacturer, we are very thankful to them. They made changes. Initially, the product was um, imported through a named patient basis through a very complicated pathway, and they simplified it, which required several steps of approval at their end, and we encouraged them to let that go. It didn't need to be that complicated, and worked on a new process, which is much shorter. So that's what we are looking at. And in this process, again, thanks to Stop TB Canada, we found there's another problem that relates to pediatric and child-friendly TB formulations that are available worldwide in developing countries. And they could be useful in Canada too. So we are trying to get to the bottom of that problem. And again, there's very few kids, but we are trying to find solutions. Hopefully, we'll be able to find a solution to that problem too. And we are fully committed to working alongside you and the physicians and Stop TB Canada and the TB community in the country to resolve these access barriers to the best of our ability. I think Canada is in a good place. You don't have a lot of disease burden, but that cuts the other way, that the few patients, people who have TB find it very difficult to get the medications. And we'll try our best, to the best of our ability, work with the regulations to find solutions for those individuals. Because we are a nonprofit, so every individual matters to us. We are not really looking at this as a profitable venture because we don't make profits, right? So please, if you see problems, tell us. Related, obviously, to the medications we work in, and if it's outside of that, we are happy to lend our thought partnership and try to find solutions. So thank you once again for having me.
Oh, thank you again, and thanks for being the bearer of good news. All right, next up we have a double act. We've got Sarah Prowse, Acting Senior Manager of the Center for Communicable Diseases and Infection Control at the Public Health Agency of Canada, and Tanya Ramsamy, who's Executive Director of the Pharmaceutical Drugs Directorate at Health Canada. Over to the two of you.
Thank you. Good morning or afternoon, I guess. I am going first, and I am looking to share my screen. So apologies, I'm not often in Zoom. Can you see my screen there?
Yes.
Yes, okay.
Yes, you're not in presentation mode yet.
How's that?
We see the slides, but it's not as, there we go. Yeah, that's good.
Perfect. Thank you so much. So I'm here to talk about our Indigenous, Federal, Provincial, and Territorial Tuberculosis Task Group that's being led by the Public Health Agency of Canada. So to give you some context, in September of 2023, at the second United Nations high-level meeting on TB, Canada reconfirmed its commitments to address TB in Canada and abroad. And our commitments include the global TB target set by the World Health Organization as part of the End TB strategy in the United Nations Sustainable Development Goals. So to that end, in September of 2023, TB was identified as a key priority by our Pan-Canadian Public Health Network. So in April of 2024, the Communicable and Infectious Disease Steering Committee convened a time-limited TB task group with a mandate to support Indigenous, federal, provincial, and territorial collaboration and meaningful engagement on TB elimination, and to co-develop a TB elimination strategy for Canada. Just for some additional context, the Communicable and Infectious Disease Steering Committee is part of a formal governance structure under the Pan-Canadian Public Health Network. And this Public Health Network Council is accountable and reports to the Conference of Federal, Provincial, and Territorial Deputy Ministers of Health, which are accountable to our Ministers of Health. Our TB task group representation includes all provinces and territories, as well as Inuit, Tapiriit, Kanatami, the Assembly of First Nations, and the Métis National Council. The development of the strategy has involved extensive engagement, and the purposes of the engagements are to identify key challenges and priorities, potential solutions, best practices, lesson learned, and what's working so far. We have used multiple engagement approaches to date, and this is ongoing, including community-led engagement with populations most affected by TB, in-person meetings, in-person visit to Nunavut, one-on-one interviews, an online survey, and virtual roundtables, which included both regional topics as well as topic-specific issues. Engagements to date have reached TB clinicians and experts, provincial and territorial public health practitioners, nurses, researchers, community organizations, as well as people with lived and living experiences, and those that work in the social services. Now, I want to note that engaging with populations most affected by TB, including Inuit, First Nations, Métis, and people born outside of Canada, as well as people with lived and living experience, is critical to inform the elimination strategy. To date, we have held 21 regional and topic-specific roundtables, reaching approximately 730 people. We've had 8 key informant interviews with people with lived or living experience of TB, as well as additional interviews with healthcare professionals, social service workers, and TB program staff. We held a roundtable discussion with the Canadian TB Elimination Network, as well as in-person regional Nunavut engagement in Iqaluit. So for next steps, the findings from the engagements to date are being used to develop and draft the TB elimination strategy in partnership with our members of the TTG. The strategy I also want to note that the strategy recognizes the ongoing actions of many organizations and groups to address TB and is meant to complement and inform this work, not to supersede it. In particular, we recognize the leadership of the Inuit Nunavut regions and ITK in their work on the Inuit TB elimination framework and their regionally adapted action plans. And this work is really important for us to learn from and build upon. Our community-led engagement with Inuit, First Nations, and people born outside of Canada is ongoing and will continue into spring 2025. And those findings will continue to inform the TB elimination strategy. And once all engagements are complete, we will draft and disseminate a What We Heard report to all of those participants who engaged. So thank you, and I'll now hand over to Tanya from Health Canada.
Good afternoon. So thank you for having me today. So my name is Tanya Ramsamy, and I'm currently the Executive Director in the Pharmaceutical Drugs Directorate, where we're responsible for the review and approval of pharmaceutical drugs focused for the treatment of TB, among other drugs. I did not prepare any slides today, and just wanted to share with you some of our current pathways, both regulatory, standard regulatory pathways, as well as those for exceptional use. So ideally, manufacturers will submit to Health Canada an NDS, so a new drug submission package, in order to receive market authorization. That enables us to review the drug's safety, quality, and effectiveness. This is a process that takes close to a year, but we do have other mechanisms to expedite those reviews. We have priority review policies, which enable shorter timelines, as well as notice of compliance with condition, which is another pathway in order to treat for drugs to treat serious and life-threatening diseases, which have promising evidence of efficacy. Now, despite having these pathways, we recognize that in many situations, manufacturers just aren't willing to submit applications to Health Canada. And unfortunately, Health Canada cannot compel a drug manufacturer to file a submission or even to supply the market in Canada, even if they do submit an application to Health Canada and get market authorization. Drug manufacturers, in fact, determine whether and when they will file a drug submission to the department, and whether they wish to seek file review under either an expedited submission pathway or standard pathway. Now, one of the things that we've done in order to try to encourage manufacturers to submit to Canada is we've designed these programs which allow for Health Canada, so Canada, to work in a collaborative manner with other countries and try to make it more attractive to manufacturers. So we have something called EMA Open, where we work with the EMA, but we also have something called Access. So given that Canada is a very small market, when you think of the US or even the EU. We have a work sharing initiative with Australia, Canada, Singapore, the UK, as well as Switzerland, which aims to strengthen the international partnership and submission review and provide sponsors with access to multiple markets at the same time. And this is often attractive to others, to manufacturers. So this is one way we're trying to encourage manufacturers to come to Canada, given our small market. Now, we also understand, and not only with TB, but with other types of, with other indications, that pediatric formulations is an issue. So in order to continue to support the availability for pediatric formulations, and after extensive review and consultation with stakeholders, Health Canada developed the Pediatric Drug Action Plan in 2020 to improve access to pediatric drugs and child-friendly formulations. So Health Canada is actually currently working on identifying areas of unmet medical pediatric needs and to explore ways to help bring these drugs to children in Canada, and we're planning on publishing the National Priority List for Pediatrics sometime later in 2025. Now, those are the standard pathways that are available to manufacturers. But for TB, like I said, it is hard. Manufacturers don't often approach us, despite the need that we have in Canada. But there are other options in terms of access. And I know you know all about SAP, and I'll speak to that a little bit later. But there's also one other option that I think one of the speakers mentioned briefly, that I don't think we've thought about in the context of TB enough, and it may not be a popular option to many of you, but there's also the clinical trial option. So generally we think of clinical trials as being experimental drugs, unproven, but we can always use that mechanism, that pathway, in order to gain access to drugs that aren't available in Canada. It allows physicians to access drugs that have been reviewed by our clinical trial reviewers, that have same safety, efficacy, but also they take a look at the quality of the product as well. Now, as you know with SAP, or you may not know that with SAP, there is no review of safety, efficacy, or quality. But in the clinical trial context, we do review that. The approval takes 30 days, and there are other requirements. So you need RAB approval, as many of you know already. And it's not necessarily a manufacturer that needs to be a sponsor of these types of studies. It can be a physician. We have developed a simplified process called the OLIP, which is the Open Label Individual Patient Study, in order to help support physicians who wanted to have access to specific drugs for a patient and didn't necessarily want to go through SAP. So this is an avenue as well that could be explored in order to gain access to TB drugs in the interim, while we continue and while you continue to advocate to manufacturers to submit to Health Canada. Now, there are other exceptional pathways for drug access. You've mentioned the ADUCT, so I refer to this as the UPHN, which is the Urgent Public Health Needs List, and this is for immediate use. Access to drugs can be put on this list if they've been authorized by the US, the EU, or Switzerland, but are not available in Canada. And this is to help address an urgent public health needs. So the pathway is intended to be used in exceptional circumstances, of which tuberculosis would be considered. So the public health officer needs to request the addition of a certain drug to this list. And as you know, rifapentine is currently on this list. Now, manufacturers who are willing to submit an application to Health Canada for a drug that is on the UPHN can have a fee waiver for their drug submission. There is also other mechanisms of access. There is the block release, which came into force in 2023, and this facilitates access to drugs for emergency preparedness or response activities by the public health officers in a public or military emergency, either for immediate use or for stockpiling. Now, the block release is a formal process where Health Canada approves the importation and the storage of a specific quantity of the drug under specific conditions, and it's typically for emergency access mechanism. And this is referred to as stockpiling. Now, the next option that we have in order to provide access, and this is the one you all know about, is the Special Access Program. But this should be the exception and not the rule. So this is it's a very it should be used under very narrow and specific circumstances, allowing special allowances to be made in order to allow the access to unauthorized drugs through exemptions to the food and drug regulations in urgent and emergency situation. Now, this allows healthcare practitioners to request this exemption for access to these drugs in a medical emergency. Now, we say the sale of the drug, but it's providing the drug. We don't handle any of the money piece that may go into this, but it broadly exempts, and this is important to recognize, that it broadly exempts all the regular protections and requirements of the food and drug regulations, which is why it should really be thought of as the last avenue of use, which means there's limited ability to manage product risk, for example, either through label changes or recalls. There is no review of safety, efficacy, or quality. Now, through SAP, there is the standard process where it's a case by case. Physicians request access, but there's also the future use, which some of you are already familiar with, which came into force in 2020 with SAP modernization, which is somewhat less burdensome process for requesting a drug previously authorized through SAP, and a mechanism that allows the manufacturers to import the drugs into Canada in anticipation of a request, so pre-positioning. But again, this is not an ideal situation, and really, ideally, it would be a market authorization. And so this is just a small overview of each of the pathways that are currently available through Health Canada. Now, I know there's been question about fee mitigation, and really within my realm of responsibility, I'm aware of some fee mitigation options. So like I mentioned, the UPHN, there's also fee remission for small businesses that is possible as well. And so I just wanted to give you a brief overview of what's available through the standard regulatory pathways. Thank you.
All right, thank you both for that presentation. So that concludes our list of presenters. We've heard about some of the challenges for access to medicines for TB, particularly in Canada, but also we've heard some positive steps. You know, we're not all the way there yet, but you know, steps on the path here. Now, despite my best efforts to be a jerk, unfortunately, we are running a bit over time here. But we do want to get questions. Well, I hope there's some questions, especially if I had to, you know, be a bit mean here. So we will be staying on. Any of our speakers who can stay a couple extra minutes, that would be really appreciated. But you know, we understand everybody's really busy. And so forth. But at least some of us will be here. So yeah, any questions can appear in the chat. And Lee will also be putting a little information about things actually happening on World TB Day on the 24th, how that's being marked in Canada. That will appear in the chat as well. So questions. And of course, speakers, you are also welcome to ask questions. It's a two-way street here.
So, if I may,
Please.
A question to Tanya. So I was speaking about the pediatric fixed dose combination medicines, which are not first line TB medications, which are not available in Canada, the WHO pre-qualified. And Tanya, I'm sorry if you mentioned it and I missed it. Would WHO pre-qualified medications qualify for the block release or stockpile mechanism in Canada? You're muted, Tanya.
Thank you for that. So are you talking about using the Global Drug Facility in order to access drugs to Canada? Or just the fact that
That
they're
could be one.
pre-qualified?
Just the fact that they are pre-qualified, but yeah, they're also available through the Global Drug Facility, but can be also, same drug can be available directly too.
So manufacturers can approach us. So, I mean, if a drug is marketed anywhere in the world, they can approach us. Ideally, manufacturers would come from market authorization, right? So we would still be required to, if they would use their standard mechanism, they would still be required. We would still be required to review safety, efficacy, and quality. Quality is a big piece. There can be a number of challenges with quality of products. We do have and abide by international standards set out by the International Conference on Harmonization of Pharmaceutical Drugs. So we do want to ensure that drugs that come in the country are safe, efficacious, and of high quality. And so, like I said, I mean, this is a challenge with accessing drugs through SAP, especially for vulnerable populations, because you can't ensure that these drugs have undergone regulatory review, and you can't speak to the quality of the product you receive. I understand, and SAP can speak to some of the additional pieces, so I'll just turn to Ian or Vivian, who I know are on the line, who can expand on this a little bit more through access via the Special Access Program.
Thanks, Tanya. So yeah, with the SAP, maybe just to clarify for everyone in the room, we do administer both the regular SAP regulations for Form A and Form B, as well as the block release applications. So both mechanisms consider requests or applications for drugs that are not available on the market. It certainly is a plus if the product is market authorized somewhere else or if it's pre-qualified, but it's not required. With that said, with block release specifically, it does require an application from a public health official. That can be provincial or federal, and this is in the same way that SAP requests are practitioner initiated, block release applications are public health official initiated. It requires them to declare that there is a public health emergency and that there is a need for access to a bulk amount of product to be kept for stockpiling and or immediate use. Neither of these mechanisms, again, like Tanya said, are ideal because they are meant to be for drugs that are not market authorized, that don't have sort of a need because it's meant for emergency preparedness and response. So again, it would be the best case scenario for drugs for manufacturers to pursue market authorization.
Got it. Thank you very much, both Tanya and Vivian.
All right. Thanks very much. We've got time certainly for one more question, maybe more if it's short, but anyone else? Or the presenters have presented the information so thoroughly that no, there are no further questions. Madeline, that looks like a hand in a video.
Yeah, I can ask one. It's kind of on the same topic, so I just wanted to give other people a chance if they had something on, but it doesn't look like it, so I'll just take the opportunity. Thanks, Sandeep. I had a similar but slightly different question that I wanted to ask as well, around if there'd been any discussion at Health Canada or at about including WHO pre-qualification as sufficient for access via the UPHN pathway. Like right now, like the access depends on the drugs being approved in either the US, the EU, or Switzerland. But I think that could be something that's interesting to explore because, as far as I'm aware, that WHO pre-qualification process is typically carried out and involves like regulatory officials from the EU, from Canada even, that are involved in that process of ensuring quality, ensuring safety? And would there be a possibility of expanding the UPHN process to recognize WHO pre-qualification, and through that would allow importation of drugs such as child-friendly formulations via that mechanism?
So I'll be quite honest, I don't have the answer to that question, but I'm happy to bring that back to the policy team and see if that's been explored previously, or if that's under consideration.
Maybe I can jump in
Oh,
here.
Vivian, sure.
Yeah, no problem. So it's actually in the regulations that it must be approved by the FDA, EMA, or the Swiss. So unless there is a update to those amendment to those regulations, this is sort of like a black and white requirement for access to drugs through UPHN.
Yeah, no, my question was if it would be possible to change those requirements to consider WHO pre-qualification in addition to those three regulatory agencies. So I think, yeah, it would be interesting to know, Tanya, Vivian, if it's something that's been discussed and what might look like to change those requirements.
Yeah, an amendment to the regulations definitely is a long process. I myself am not aware of any proactive discussions on that recently. But again, like with UPHN, it's UPHN is also initiated by a public health official for drugs to be added on the list, and it definitely has some safeguards in place in that product can be imported, but must meet XYZ. But those XYZ, that's basically the only requirements. So the fact that it's approved by the FDA, the EMA, or the Swiss, that's meant to be a very bare minimal requirement. But we can certainly, if there are opportunities that arise internally, we can bring that up with the risk management division that handle the UPHN.
All right. Thank you very much for that. Thanks also for additional experts joining the call to provide this information. So thank you, Vivian, for example. I think that is going to be it. We've gone a bit over time today, but thanks again to all the speakers, really diverse list of folks from a diverse list of bodies and agencies. So thank you all for joining us. Again, this has been recorded, so I know some people came in late. You can check in and watch what you missed, etc. I'm sure StopTB Canada will indicate when that's online, etc. So thanks again. I don't know if happy is what we say about World TB Day. But it's an important day for everyone on this call. Coming up next week, there's ways we can observe in Canada. So I think everyone on this call, we all want to end TB in our own ways. So thank you all for joining us, and we'll see you next year. But we'll also see you hopefully in between. Thanks very much.
Thank you. Bye.